Joining me now to discuss psoriasis and psoriatic arthritis is Dr. David Sikes. He's a practicing rheumatologist who has an interest in treating patients with severe psoriasis and other severe skin diseases. Dr. Sikes, welcome to the show.
Thank you, Robert.
So glad to have you. Let me go ahead and start out with the causes, because it seems like there's a lot of mystery to it. It seems hard to pinpoint what the causes are. However, there seems to be some kind of a link to genetics, the immune system, and other various triggers. Can you address this?
Of course. To begin with, psoriasis is a disease where the patient's immune system is attacking the patient. So that's the fundamental underlying problem with the disease. And we think at this point that the primary reason that people get psoriasis is actually based on their genetics. Most studies have shown that 40% of patients with psoriasis have a family history of psoriasis in someone that's a first-degree relative. In other words, a mother, father, brother, sister, or child. It also, if you look at twin studies where they're identical twins, in other words, the same genetic material, psoriasis is much more likely in identical twins than it is in twins that are just fraternal twins. So that's one of the triggers, or that's one of the reasons that we think that people get psoriasis. But there do seem to be some triggers also.
And what would they be?
The things that would seem to make the most sense to most folks. Some are obvious and some are not so obvious. One, of course, is smoking. Smoking cigarettes appears to be a significant risk factor for psoriasis. Another one that we in rheumatology and with folks that see a lot of psoriasis patients is obesity. Patients that have a high body mass index, in other words, they carry a lot of extra fat, are a lot more likely to develop psoriasis than people who are thin. Drugs have been associated with the onset of psoriasis. Most common are drugs that are heart drugs, like beta blockers, for example, and also drugs for treatment of malaria. One interesting little tidbit is that one of the medicines that we use to treat psoriasis, or one of the types of medicines we use to treat psoriasis, what's called the TNF inhibitors, like Enbrel and Humira, not only can they treat psoriasis, but they can also cause it. So it's one of those weird paradoxes in medicine. There's some infections that have been associated with the onset. Alcohol consumption has been linked to psoriasis also. And probably the one that I think is the most preventable, I think, is probably vitamin D deficiency. There seems to be a pretty good link with vitamin D deficiency in psoriasis.
Interesting. Now, there's a number of type of psoriasis, and I think most people are probably familiar with plaque psoriasis because it's mentioned on ads on TV all the time for different treatments. Yeah. But can you describe the different types of psoriasis there are?
Well, the types the one that we normally see, as you mentioned, is plaque type psoriasis. It's the raised red, silver scaly plaques that you see on people's elbows and their knees. And if you see the ads and you see pictures of people in the ads, they usually have plaque type psoriasis. There are several other varieties, and without getting into a whole lot of detail, right. One is guttate, and they're just little spots of psoriasis all over instead of the larger plaques. A more severe form is called pustular psoriasis, which is as it sounds. It's pustules or little pus pockets that's actually in the skin and is really a form of psoriasis. And then there are even more severe diseases where people will get total top of their head to tips of their toes. We call that erythrodermic psoriasis. And then some people instead of getting the normal plaques on the elbows and knees and on the extensor surfaces, sometimes people will get it like in their groin and they'll get it in their armpits and not anywhere else. That's the opposite of the normal pattern. We call that inverse psoriasis. And some people just get it on their nails. And the nail-type psoriasis we see that's fairly common in patients.
And can somebody have it so bad, you talked about head to toe, that it actually affects them from functioning?
Oh, absolutely. Yeah. There are actually a lot of patients. The number of people who have psoriasis, there's a significant amount of argument about, how many people in the population actually have it. but it's probably somewhere in the 5% range of folks have psoriasis. Most of them have mild disease. They have a few little plaques that kind of come and go and that are not really severely affected by it. But then there are a number of people who have truly life-threatening disease where they have such severe psoriasis that it can threaten their life. But most people don't have that, obviously.
Right.
And one thing about psoriasis that's interesting is, to me, and I think one of the reasons that I'm interested in it, it's because psoriasis not only affects the patients in terms of their skin and the areas that are affected, but it affects how they interact with other people. Because folks see someone with psoriasis, they see the plaques, they think it might be infectious, or they think that they might be able to get it from them. And patients with psoriasis a lot of them don't like to be touched. They kind of lose the ability to touch other humans, and it's very distressing. So it's one of the things that kind of led me to interest in this area.
Yeah, and let's be clear, this is not communicable from person to person.
That's correct. It's absolutely not communicable. It's a disease that you're not going to get from touching someone else.
Right.
It's okay to touch people with psoriasis. You're not going to get anything from them. They're not going to get anything from you. Okay,
and you directed some fingers at the immune system and genetics. So is this a lifetime condition?
It can be very sporadic. The milder patients, sometimes people will go for years and never have a problem, and then suddenly you'll have a big outbreak. I see patients frequently that have disease that started when they were teenagers. They got severe disease in their teens and 20s, and then it went away and then came back again in their 30s and went away and then came back in their 60s. So you never know. It can come and go. Some people have disease that just starts and it never gets better, and some people it comes in spits and spurts. I will tell you, the majority of people that we see, it does tend to kind of get better and worse on its own. Okay.
Now, how is psoriasis diagnosed?
Most of the time, and I'm a rheumatologist, so I'm not a dermatologist.
Right.
Most of the time, we like to work closely with a dermatologist in managing our psoriasis patients. And I usually like to make sure that the dermatologist agrees with us that the diagnosis is psoriasis. There are really two ways to diagnose psoriasis. One is it looks so characteristic that you know that that's what it is. Mm-hmm. We like to use the analogy in medicine that if it walks like a dog, barks like a dog, wags its tail like a dog, it's probably a dog, and you don't need a DNA test to know that it's not a wolf.
Right.
But some patients, if you absolutely have to have a diagnosis, or it looks funny, or there's something unusual about it, the dermatologist or we can take a real small core of tissue, we call it a biopsy, just a little tiny plug of tissue out, you numb it up real good, and take that plug out, send it off to the laboratory, and a pathologist will cut it up into small pieces and look at it under a microscope and can tell us that it's psoriasis and be positive.
And what would he see under the microscope? I'm curious.
There's a number of findings. It depends on exactly which type of psoriasis we're talking about, but there's usually just an exuberant overproduction of cells, and that really kind of typifies the plaque-type psoriasis. It'll just be, huge numbers of cells that just don't belong there, and they just overproduce and overproduce and overproduce, and that's what the immune system seems to do to the skin. It's
autoimmune attack. Yeah.
Yep, absolutely.
Yeah. Now, people with psoriasis and psoriatic arthritis are at an elevated risk of developing other chronic and serious health conditions, and these are called comorbidities. What are these comorbidities?
As you would expect, we've kind of touched on a couple of the areas already that are a risk. But patients who have psoriasis, and the more involvement, the more skin involvement, the greater the body surface percentage. In other words, some people may have little tiny spots, and that's all they have, which is just less than 1% of their body surface area. But as they get more and more covered with psoriasis, their risks start to go up. And the 5 to 10% range, where people develop 5 to 10% of their body surface area that's covered, you start to get into a significant risk of things like diabetes is much more common in that group of patients. That patients can get high blood pressure, they can get high cholesterol, and what we found in the last 10 years or so looking at psoriasis patients and psoriatic arthritis patients for that matter, is they also have a much higher risk of developing heart attacks and strokes.
Wow.
And as a result, actually are more likely to die.
That's absolutely fascinating. Okay, now there's a number of treatments out there. And we're talking about topicals, oral medications, and several others. Briefly, what is out there, and what's the success rate of some of these?
Well, this is an area that you can ask a dozen experts and get a dozen different opinions.
Mm-hmm.
And I'm expressing my opinion as a rheumatologist, not as a dermatologist.
Gotcha.
Patients who have milder disease that have a few spots, or they're less than 5% of their body surface area, they generally do very, very well with what we call topicals, which is some type of a cortisone medicine mixed up in a cream that'll penetrate the skin and will go into the plaque or into the psoriasis, and often that will heal up the plaque for a while, and it'll make it go away. And sometimes if you've got a patient that it kind of comes and goes, the patients will do fine, or they'll only have to apply the creams with a cortisone type medicine in them a few times. They'll have to do it for a couple of months, and then the patients will, and then the plaques will get better. Some people have to apply these things continuously to keep the psoriasis gone. That's one way that we treat this, and that's probably the mainstay of patients who have milder disease. Patients who have psoriasis often do very well with light therapy, and there is something called phototherapy that the dermatologists do, and basically it uses light to cause the psoriasis to get better. I don't know if anybody knows anybody with psoriasis, but often the old remedy for them is to go to the beach and go in salt water. Most of that is actually probably sun exposure, because sun exposure is like UV therapy. Right. Exactly, and patients do beautifully. And a lot of patients get better with light therapy. So those are the two mainstays that the dermatologists use. There's some other things other than cortisone that they can mix up in the creams to have effects, but that's the typical treatment. What my area of interest is as a rheumatologist is that if patients have more severe disease than just a few small plaques, something that's more than a nuisance, those patients, especially if they have a large amount of their skin that's involved, it's almost impossible to apply enough cream on them to control the disease. And in those patients, we found that we have to use medications, in other words, systemic medicines, where the patient takes a pill or takes a shot to control the disease. And that's what we focus on in our clinic. We have a dermatology clinic that we run in Florida Medical Clinic in Land O'Lakes, and we focus on those patients with more severe disease. That's what we do, and the topicals work well. The phototherapy, the light therapy works pretty well. Some of the older medications that we use for both psoriatic arthritis, rheumatoid arthritis, and also psoriasis is called the mainstay is called methotrexate, and it's an older medicine. It has some side effects. It can cause problems, but it sometimes clears patients up really nicely. About 40 to 50% of patients get a really good response to that medication alone. But some patients have much more severe disease than that. And some people who have large areas covered in their body, or they have involvement of their face, or they have involvement of their groin, those patients often need to have more aggressive therapy. And we often use the medications called the biologics. And you've seen the ads on TV.
Sure.
For Humira and Stelara, and there's a newer drug that's just come out called Cosentyx. And each of those medicines, as they come out in progressive generations, Humira does a nice job. It works really well in about 50% of patients in our experience. Patients that take Stelara, which is another medication, you'll get a 60% response. and the newest medication like Cosentyx. All of these are injectable medicines, and they're very expensive, but generally covered by insurances. Or if patients don't have insurance, we can usually get the drug for free. But Cosentyx clears a very large percentage of patients. And when I started in rheumatology years ago, we rarely talked about clearing psoriasis. We almost never talked about that. We were happy if we got a 50 or 60% improvement in the amount of skin involvement. Nowadays, we frequently talk about clearance, in other words, no detectable psoriasis. So it can be life-changing for patients
Sure.
that have severe disease.
What kind of side effects are we talking about?
There's always whenever you see a patient and you talk, and whenever I see a patient and talk to them about the disease and the treatments, you always want to make sure that you explain that there's a risk to benefit. Some patients get dramatic improvements. It's life-changing for them, and it might be worth the risk. If they have a relatively small amount of psoriasis, it's probably not worth the risk of using a systemic medication. But these people that have large amounts of skin involvement, we frequently see patients that just they don't ever go out because they're so embarrassed by how they look. Mm-hmm. Those are the people those are the people we focus on. That's who we like to see in our clinic. But so what happens is we always have to make that risk to benefit ratio. So side effect wise, with methotrexate, the older medicine, some patients will get sick to their stomach when they take the medication. It's about 20%. And some people can have low blood counts, and you can develop liver problems down the road. And so we have to watch the patients real carefully and real closely. The newer medications like Humira and Stelara and Cosentyx, they work differently. They actually work very selectively, specifically on very particular parts of the immune system. And so their side effects are a little bit different. Anytime you give a shot or you give any kind of medication, people can be allergic to it. So there's an allergy as an issue. They can have a reaction to where the shot goes in. You can get a red spot. That can happen. The other thing that we worry about probably the most is that there may be a slight increased risk of infection. And that does seem to be a problem in patients with psoriasis, but not as much as some of the other diseases that we treat. And the infections that we worry about are things like hepatitis B and tuberculosis. Right. Those we can test for ahead of time and make sure people don't have them. We also usually recommend that people have had the vaccine for shingles, because these medications may bring shingles out also. So those are some of the infections that are involved. But some people get more colds and they get more serious infections like pneumonias and things. But by and large, the risk is fairly small of infections. Not to downplay it too much, but there is a risk. And then of the other things, there's a whole laundry list of other things that are odd that we really almost never see. We have a population of at least 1,000 patients that have autoimmune diseases, over 1,000 patients just in my practice. And most of them are on medications that change their immune system. And a lot of the things that you see in the list on TV when they talk about all the side effects, we almost never see them. Oh, okay. I can address, any of them individually, but, by and large, they just don't seem to happen very often. They are important, but they're quite rare.
Okay. Let me switch gears a little bit. I got about 4 minutes left.
Okay. And
up to about 30% of people with psoriasis develop psoriatic arthritis, and this can be some pretty serious stuff.
Actually, as a rheumatologist, we see, the way I started seeing psoriasis patients was through our psoriatic arthritis population. It looks like about 5% of the population gets psoriasis or somewhere in that range. And on the order of about 10% of those patients will develop psoriatic arthritis. And it is important that if a patient has psoriasis and gets painful joints and swollen joints, that they're seen by a rheumatologist, because psoriatic arthritis it's very important to diagnose early and start treatment early, because it can cause damage and destruction of joints and can actually be crippling. So we recommend that patients that have psoriasis, that develop swollen or painful joints, that they're evaluated by a rheumatologist to start treatment if they have psoriatic arthritis, so that we can kind of move forward with treatment in those patients, because psoriatic arthritis can be a very difficult and damaging disease, and also increases the risk of cardiovascular disease, and heart attack, stroke, and may also increase the death rate. Appropriate treatment may reduce the risk of those kinds of bad things happening.
Okay, and lastly, no pun intended, but children are not immune to getting psoriasis. So what, in about a minute, what info can you give parents about what they can do and what to look for?
Well, I generally like to one of the things I would recommend is if children get lesions, they want to go ahead and, if they get sores or any kind of plaques or any kind of skin disease, you clearly want to see your pediatrician. That's where you want to start. If you want information about psoriasis, I would recommend that you go online and go to the National Psoriasis Foundation website and pull up information about the disease process. It's an excellent site, great organization. I've worked with them now for a while, and they do amazing work.
Okay, excellent. Well, this was incredibly informative. I appreciate it so much. Thank you, Dr. David Sikes, for your time and expertise.
Thank you, Robert.
Have a great evening.
Yes, sir.
Okay. Well, Dr. Sikes mentioned the National Psoriasis Foundation, and they are the largest organization focused solely on psoriatic disease. The mission is to drive efforts to cure psoriatic disease, improve the lives of those affected. To date, they've invested $13 million in research, and earlier this month, they launched our Patient Navigation Center, which helps people with psoriasis and psoriatic arthritis obtain information and treatments necessary to manage the disease. And I encourage you to check it out if this is a topic that is important to you. To learn more, visit the website www.psoriasis.org.